All right. Three, two, one, needle pod. We are off to a start here. It's Dr. Ellison Melrose with the needle pod, and I am joined today with a fellow Institute of Clinical Excellence faculty, April Dominick. So, for those that don't know April, she is a teaching assistant with the Pelvic Health Division of ICE, and she is also becoming a lead faculty because she is creating her own pelvic floor course for male pelvic floor dysfunction and the anal rectal exam. So, April, thanks for coming on today, first of all. And for some of our thousands of listeners who may not be familiar with your work, tell us a little bit about your background in pelvic health and what led you to want to develop the course in male pelvic floor.
Thanks for having me. I've been stoked and waiting to hop on. So, dreams really do come true.
Love that.
Yeah, I have been in pelvic health for about 10 years, and I started all because I was in ortho first, and then one of my coworkers was working with some pelvic health clients, and every time they came in, I would hear them behind closed doors, and they had such a blast, like
Yeah.
laughing, giggling, just it seemed like they were having so much fun, and I was like, I went in on that. So I took a course in pelvic health and I was like, let me just dip the toes in. Like, just because I'm taking this course doesn't mean I'm actually doing this.
Yes.
And so I took the course and, as soon as you start with pelvic health, you have to like get some patients to get some practice. That it was like Pringles, once you open the can, you can't stop. Waitlist grew. And so I ended up doing like half pelvic, half ortho for quite some time. And in my journey at working at a big hospital system, I was actually had the opportunity to help start a brick and mortar pelvic health center, which was so cool because we integrated disciplines between like colorectal, urology, OB-GYN, like all of the systems were working, or all of the providers were working together. And I just loved being able to better understand what was going on from the medical side and have a place for the clients to be able to, get all of the care that they needed all in one place. And then after I did that, I ended up working on starting a satellite pelvic health program at one of our other outpatient ortho clinics. And so, yeah, I just got a lot of experience with the marketing side of things and referring and communicating with physicians. And then I moved out to Denver and worked in a PT owned practice for pelvic health. And then I am currently owner of a clinic, cash pay paste, something like
Tongue twister. Yeah.
clinic now in Denver, Colorado. I treat mostly pelvic floor conditions and then a mix of anything in between that comes my way with a lot of male conditions and pregnancy, postpartum, anything under the sun.
Yeah. Yeah. And then tell me, I guess, first of all, I didn't even know all of that history, and we've been friends for like 5 years now.
Yeah.
So didn't even know some of that. So that's awesome. You had a ton of opportunity kind of right out the gate to just kind of dive right into pelvic health and I think that marketing side and getting comfortable talking to other providers in this community or that treat these patients is a skill that not a lot of us have or have had access to. And I
Sure.
think that's so helpful, especially with owning your own practice now, too. So tell
Yeah.
me, how did the opportunity come for you to create this course?
So for the ICE Physio Live Pelvic Male course, that's what we're calling it, versus our Live Pelvic Female course, which has been going strong for the past few years, we realized that there was a huge need for two things. Number one, in our live female course, we go through the intravaginal exam and assessment, and that's only part of the entrance and exit to the pelvic floor area. For some folks, they have that vaginal entrance, and some folks have vaginal and anal entrance, and some folks have just the anal entrance. So we realized we needed a space and a course dedicated to doing an anal rectal assessment, which is going to be huge for anyone, no matter their genitalia, any clients, because it's a way that we can assess bowel dysfunction like constipation or fecal incontinence or fecal leakage, as well as tailbone pain. So that was one of the first reasons we decided to do another course. And the second reason is because we have this huge population of males who are very underserved in the pelvic space. And we decided that it was important for us to have a course dedicated to figuring out how to treat and be confident managing individuals who are assigned male at birth who haven't undergone any gender reaffirming surgeries, to really focus on that population and getting them the care that they need and absolutely deserve.
Yeah. Yeah. Why? So, with male pelvic health being so underrepresented in our field, why do you feel like, why do you think that is? First of all, do you think it's a provider problem?
Mm,
Do we feel like it's undereducated in the patient population? Like, tell me a little bit more about that and maybe where some misconceptions for clinicians that we can kind of help clear up some of those misconceptions around male pelvic.
yeah, that's an interesting question because I think in a lot of ways, our society has done women a disservice in health care. But in this space, it's very interesting in the pelvic space. I think when people think of pelvic floor, both the community members and healthcare providers, I think a lot of times they think pregnancy, postpartum. You only have a pelvic floor if you have undergone any of those conditions. And so,
Definitely.
from that historical perspective, it's been more popular in the pelvic space for for females who have certain life transitions that we expect some disruptions in their pelvic health. So, like I said, pregnancy, postpartum, and more recently, the menopause transition. In males, there's not really a time or a life transition that we expect some sort of dysfunction to occur. So I think that's one of the many reasons, right,
Hmm.
that it's not really talked about openly in the
Yeah.
community and in society until probably like in the late 1990s when Viagra came out and it was FDA approved. And so that probably got people talking more, but that's also more on the pharmacological side of things
Yes.
versus the pelvic space. So I think, it's important for clinicians to become more comfortable treating this population because there are just so many males who are suffering from pelvic pain or bowel dysfunction or sexual dysfunction, and they're just suffering in silence and kind of being bounced around the healthcare space, if at all, if they even decide to
Hmm.
tell their provider about it. I think it's important for any rehab provider, not just, someone who's specifically pelvic trained, but anyone to have some sort of foundational baseline knowledge of what goes on in pelvic settings or like how we can provide some interventions for those individuals. Because even if I get so many referrals from ortho providers, which I love because we as rehab providers have so much time with these individuals and we develop that rapport. So if we can even get good at just asking, hey, how's sexual function going? Anything awry there or any bowel issues or urinary issues? If we can even literally just ask the question, you would be so surprised how many people would A, be thankful for you even asking, and B, be grateful that you have either interventions that you can do for them or that you can refer them to someone who does do
Yeah.
pelvic care.
Yeah.
So, yeah.
So you listed a couple different brands of male pelvic dysfunction, right? You had pelvic pain and then bowel dysfunction and then sexual dysfunction. Of those three, let's kind of highlight some sexual dysfunction because this is an area that, as ortho, we're used to treating pain too,
Sure.
and I think sexual dysfunction, like you mentioned, it's something that we don't talk about enough. And so I guess what I'm wondering is like, what does male sexual dysfunction look like in the clinic? And are there things from a musculoskeletal perspective that can affect that? Or, yeah, let's talk a little bit more about what that looks like. Yeah.
Sure. So when I think of male sexual dysfunction, probably the two most popular pieces that come to mind are ejaculatory dysfunctions and erection dysfunction. So ED is what people abbreviate that to. And I'd say the third one would be Peyronie's disease, which is when there are some plaques that develop inside the penis, which are going to sometimes interrupt erectile function. So we'll start with the erectile dysfunction side of things. That could be a number of things. Like clients can come in, say, if you ask them or if they actually bring it up, you may hear things in the subjective like, yeah, I've noticed that my morning erections have diminished some. Like they're not as frequent as they used to be. Or I am able to achieve an erection, but gosh, it just dips down pretty quickly. So
Mhm.
I have trouble maintaining that erection once I get one. For so and then also maybe like firmness. So
Mm.
it's just not as firm as it used to be. So those are the main considerations from a subjective side that you may hear. And then ejaculatory disorders, you may hear folks say the most common thing is premature ejaculation. So the research is mostly only focusing on intravaginal latency. So, how long can someone insert into the vagina until they ejaculate? It's an issue if it's, well, we deem it an issue from the healthcare standpoint if it is less than 1 to 3 minutes upon penetration. So, if someone is ejaculating prior to that, then we say that's premature ejaculation. Um, and other ejaculatory disorders would be inability to ejaculate, so an ejaculation, or delayed. Nothing comes out when they expect that something would come out.
Okay.
Yeah.
Interesting. And I think there's a couple, like, maybe misconceptions around
Mm,
erectile function and things like that, and how much control we have as providers. But from a musculoskeletal standpoint, is there something that contributes to that we can control there? So that's one question I have, and we can pause there. I guess, is there also a warning sign or something? Because like you said, we don't have menopause in males where we know hormones are going to change
sure.
drastically and we might see some changes in their sexual function or pelvic floor function generally. But is there something that if folks have X, it will lead to sexual dysfunction?
So that's an interesting question. I actually feel like erectile dysfunction is more of a warning sign for other things.
Okay.
I geek out and I nerd out about this whole erection like process and cycle. It's
Yeah.
incredibly fascinating and extremely complex. But first off, if someone's coming in with erectile dysfunction, I like to say hard health is heart health. So if someone's coming in with some difficulties with erection or is diagnosed with that, we have some literature that is pretty astounding that says 3 to 5 years after that erectile dysfunction diagnosis,
Okay.
many individuals will develop some sort of cardiovascular event or cardiovascular disease, like a stroke or heart attack or something like that.
Wow.
Um, and so that is where I think our role as a rehab provider in simply screening for erectile function is so incredibly important because a lot of people don't go to their primary care provider yearly, right?
Hmm.
But they may be coming to us. And if we can, if we've got someone who has signs of erectile dysfunction, or maybe they've got some like diabetes or other comorbidities that would affect the vascular side of things, which is extremely important and the foundation to getting an erection because the erection is going to start with blood flow coming in. So if our vessels are not equipped or they're not the most healthy, the penile arteries are the ones that will be affected first. And because they are smaller, so if there's like gunk in them, then they are going to demonstrate,
Sclerosis. Okay.
yeah,
Yep.
yeah, or plaque or whatever, or
Yeah.
if the veins aren't working well, they're not
Yeah.
closing
Okay. Yeah.
to maintain that erection,
Rigidity.
um,
Yeah.
that rigidity, then it's going to come up in the penis first before the heart. So that's where that
Crazy.
piece comes from of like erectile dysfunction is actually maybe more of a precursor to cardiovascular disease.
Yes.
So that's point one. Point number two, you asked, when in that erectile process does maybe like musculoskeletal considerations come into play? We'll say pelvic floor is going to be our musculoskeletal plater there. Lots of nervous systems are involved in the erection itself. I'll just kind of break it down into 6 steps. The first, just 6.
Just simple 6 steps.
Yeah. The first step is some sort of sexual stimulus has to happen. So whether that is something on the head of the penis, a squeeze or some sort of palpation, or some sort of visual or auditory sensational
Arousal. Yeah.
piece that helps with sexual arousal. Once that happens, that then signals the release of nitric oxide to start the erection process. Once nitric oxide comes available, then there's another chemical that is involved in relaxing the smooth muscle inside the penile tissue. That smooth muscle relaxation starts bringing in blood flow. And so that kind of starts the erection process,
Okay.
which
Love the
then,
visual. For those that can't
yes,
see, April is using her hands to demonstrate what is happening.
erection. Dun, dun, dun.
Yes.
So once vasodilation happens and blood flow gets into the penile tissue, if enough gets in, then it's actually going to compress the veins, which keeps the blood flow in the penis so that you maintain that erection. Now, it's not until now, so we're like 4 or 5 steps in, until the pelvic floor muscles help to maintain the rigidity of the penis. So they enhance the rigidity by contracting against the penile tissues. Then, and there's some other things that happen, but that's basically where the musculoskeletal piece comes into play, which is pretty fascinating that, it takes all these other nervous systems and reflexes to occur before the musculoskeletal system really comes into play there.
Yeah. So more systemically, like you were
Yes.
saying, like vascularly, all of those things have to line up
Mhm.
before really, I guess, we consider physical therapists as musculoskeletal experts, right? That's like one of the things. We have many other, positive things about our profession as well, but that's like what we think of. And so, yes, we're maybe not playing as big of a role from a musculoskeletal perspective as we I don't know. I mean, I know there's
Right.
other things, and so I want you to tap into, like, what our role is
Yeah.
in this space too.
I'll backtrack and say one other thing.
Okay.
Once sexual arousal starts, another way the pelvic floor muscles can play a role is in order for blood flow and vasodilation to happen to get into the muscles, the pelvic floor muscles also have to be able to kind of relax and
Okay.
assist that process. So
Okay.
it's really cool that we need both ranges of motion, both ends of the spectrum. So at the very
Yeah.
beginning of the process, it's not the biggest role, but if those muscles are and your nervous system is and just
Yeah.
upregulated, then that increased tone may inhibit or diminish the potential for an erection. And then all those other chemical steps happen. And then we need that contraction of those pelvic floor muscles
To maintain
to
that.
help to maintain the
Help maintain
rigidity.
that.
So I think there's a nervous system piece that we can play into in addition to making sure that the muscles have the flexibility and the ability or the capacity to go into both a relaxed state and a
Mhm.
contracted state. So that's where our role comes in for helping someone with erectile dysfunction.
Cool. Good, because I do say that it helps to initiate, like, it helps to facilitate an erection too
Yeah.
and maintain an erection. That's something, that's how I was originally trained when I learned about male pelvic floor dysfunction or male sexual dysfunction, I guess. So I'm glad I wasn't completely lying to my patients
No,
about
not
that.
at all. Yeah.
But you're getting super nerdy about this. And
I
so
know. Sorry.
I love it. I love it. But so for clinicians that don't normally treat pelvic health, or it's a patient that comes in and you're screening out things and you just start talking about sexual function, or on their intake paperwork, they put Viagra or something like
Mhm.
that down that cues you to like, this is what this could be going on. What are some non-pelvic health, like if we're not in the pelvic floor space, are there things that they can be doing to help improve their sexual function? Or like what would be our role outside of a pelvic health physical therapist to promote sexual function, optimal sexual function?
Yeah. I think my answer for that is gonna really fall into education. Like, I had a discovery call yesterday for a man who's in his 80s, like, love, get in here,
Yes.
and he had erectile dysfunction, and he was wondering what he could do about it, and he hadn't gone to a urologist yet, and so I was like, "Ooh, the pelvic floor plays a role. I can certainly help screen and walk you through that, and I would love for you to head to your urologist as well
Okay.
to, screen some medical pieces out. But in the meantime, come see me and we can work on all of these other things. Like he didn't know about vacuum erection devices, which are really helpful for folks who maybe the Viagra and the Cialis is not working for them. And just as a FYI, Viagra and Cialis, or they're called PED5 inhibitors, they enhance what your body already is able to do. So they don't
Okay.
create the erection necessarily, but they help enhance blood flow in. So if that's not working for someone, then something like a vacuum erection device is really helpful because it just kind of like creates an erection locally
Mm,
and then someone can go about their business. So I just
got
thought it
it.
was very interesting for him because he hadn't yet seen a medical provider, but I gave him so many tips about explaining the erection cycle, which he
Yes.
didn't understand. Um,
Who does unless they, yeah.
yeah, and then I said, he had taken Viagra, but it hadn't worked for him, but he'd
Okay.
only taken it a couple times. And so I was like, well,
Yeah.
maybe you need to talk with your pharmacist about changing the dosage of that, or maybe going on Cialis, which is kind of like a low dose daily dosage or prescription versus
Mm,
Viagra, which is like more, you can do like more on demand, like
rapid.
when I'm ready. Yeah. Um, and then, so back to the original question, which you said, what can we as non pelvic providers yet do to help? We can educate on the erection cycle, that process. We can talk about exercise, like
Mm,
erectile dysfunction can happen because of lots of systems, whether it's vascular, whether it's neural, like neurologic. So folks who've had any surgeries that maybe the nerves have gotten a little shocked. And so that
mhm.
signaling that I talked about in the first few steps of an erection, that signaling is not happening. And it takes
Yeah.
some time. An example would be a prostatectomy. So those nerves, when the prostate is removed, those nerves are shocked. And so the erection process can't happen for a long time. And it takes some many months for that to recover. So it could be that.
Yeah.
It could be stress, right? It could be a psychological performance anxiety piece, or it could be the pelvic floor. And so I think someone who doesn't have necessarily the pelvic floor education just yet prior to taking the male course at
Mhm.
ICSU, they can act on those other pieces. Like if you are presented with someone who is kind of like an anxious bunny and seems to be really regulated and tense all over, then let's, get them some hip mobility, get them some back mobility, get them some diaphragmatic breathing to help down regulate the whole system. If they're not really exercising and they also present with some systemic issues like the cardiovascular disease and diabetes, et cetera, then let's teach them how to exercise and get even
Right.
some aerobic activity in to help with that blood flow and help reduce those comorbidities and enhance the health of the vascular system. And then, yeah, just even I think talking about pelvic floor in general can be helpful if you have a baseline knowledge of that.
Yeah. Okay, I love that stuff. And then for me, like my head goes to how else we can help this. And we're on the needle pod. We're here to talk
Yes,
about some
let's
needling,
go.
right? Like obviously I always need to layer in needling. And so
Yes,
for me, one thing that I think of is with dry needling, we can affect so many of those systems, right? Like we see vasodilation occur when we
yes,
needle, even proximal tissues, we see it peripherally
Totally.
happening.
Yes.
We can impact how the nerve firing rate, right? Decrease latency in nerve firing, and we can improve muscle output and all of those things. So, where does, if it does,
Mm.
where does dry needling fall into your clinical practice when it comes to sexual dysfunction?
I love that you brought that up because that is also absolutely something that someone who isn't pelvic trained can do for the person who comes in
Cool.
with some male
Yeah.
sexual dysfunction. I think where I use it, if we're talking about, let's say, the diagnosis of sexual dysfunction, I think I alluded to part of the erection process is through nerves. And so making sure that the nerves are firing well is really helpful in those scenarios. And like you were saying, kind of zooming out and affecting pieces like the sacral multifidi, and like doing some sacral neuromodulation to just help the pudendal nerve, which is basically how those pelvic floor muscles come on for erectile rigidity,
Sure.
S2, 3, 4. If we can start there, that's where I often start because for some folks, talking about if this is their very first time for dry needling, there may be a little hesitancy in dry needling the pelvic floor. Not for
Yeah.
everybody, but for some, that's where I start. Just like, especially if they have higher irritability, that can be a great place to attack the nervous system and help that reflex of the pudendal
Yeah.
nerve to help firing from a zoomed out perspective. And then I can also add in like obturator internus or some of those more superficial muscles that are directly involved in an erection or ejaculation, which is the ischiocavernosus and bulbospongiosis. So I think those would be the muscle pieces, or just like pairing the sacrum with some of the greater hip muscles can help also have
Yeah.
a great
I was
effect
just
of
thinking
like,
like glutes, like
yeah,
big old pumps, like let's vasodilate the whole pelvis. Yeah.
yes,
I
yes.
love it.
And I've had so many people who, at least for sexual dysfunction, maybe even for like some groin pain considerations, who come in, maybe that's what we do because they don't want to do a pelvic floor assessment just yet. And it's pretty incredible how just a little bit of dry needling has such a huge and profound effect on the nervous system and on these sexual function, because I've had some folks who literally like the next day or two I get an email and they're like, April, I haven't had like any sort of rigidity or a morning erection in years. And I was able to get a little wake up call, a little like flag that
Yay.
is rising. And if we think about it, like from a psychological standpoint, the confidence level that brings them, that, hey, my parts aren't broken. They just needed a little boost. That psychological piece that is affecting so many folks who have any sort of sexual dysfunction. Gosh, does that just like wash some of that away and remind them, okay, I've still got it. Like I just need a little
Yeah.
boost.
I still got it. That's right. That's so amazing. So what can we expect to see in your male pelvic course? Like what should we have pre-existing knowledge in this space, or yeah, tell me a little bit more about the course specifically.
Yeah. So for the course, we there is no prereq for any sort of pelvic health courses prior to, which is great. So come one, come all. You do not need to have someone with a penis to participate in the course. We are going to be working with whatever body comes in. So if you don't have that genitalia, we're still going to be able to work with you. We are going to use different models to kind of act as the penis, the scrotum, the external genitalia, so that we can practice like draping and things like that. Because I think that's one of the biggest barriers for some clinicians is, how do
What to
I,
do with the penis?
yeah, what do I do? So we'll take care of that. No worries there. And we'll be, like we said earlier, doing the anal rectal internal exam. Again, that's helpful for anyone with bowel or pelvic pain conditions, especially around the anus. We'll be talking through, besides pelvic pain, we'll do sexual dysfunction for males specifically. We'll go through bowel dysfunction, and then some tailbone assessments and treatments, as well as a prostatectomy and hernia topic. And for all of these, it's mostly a lab heavy weekend with some lectures littered in there. And The other thing that I think will do it really well is just weaving in that fitness forward aerobic and resistance training, which is very important, very relevant in this space in order to get some of those long-term changes. So that's probably what makes this course more unique than others out there.
That's so awesome. I'm so excited. I wish I could be at the first course with you. Tell us when to expect this on the road and where we can find, yeah, where will you be this year?
Okay. Um,
Yeah.
the first course will be June 6th and 7th in Hendersonville, Tennessee. And then we've got September 19th and 20th in Longmont, Colorado, and possibly something coming up in October, TBD. And then we've got November 6th and 7th in Minneapolis, Minnesota.
Awesome. So you're
Yeah.
kind of all over the country.
Gotta get all
Um,
my peeps.
Yeah, that's so exciting. I love that. We're about to wrap up here. So I did want to just leave you with one other question. What would you tell your younger PT self about what to expect going forward? Or, yeah, is there one thing that you would tell your younger PT self?
Like some advice, I guess.
Yeah, advice or what to expect out of the next decade of your
Hmm.
career.
Oh, wow. Okay.
Yeah.
I think I would tell myself to do less better.
Yeah.
I think that whole, like, PT school, at least for me, back when I did it 10 years ago, we were given a lot of stuff. And so that ingrained in me that I had to do it all in the first session. And in
Right.
reality, I think what I found is that people are more appreciative of someone who is very honest in like, we're going to try this trial treatment first and see how your body responds and not overload you with all these things. This is what
Mhm.
I think is going on. And so let's start here and prioritize that with your concerns that you come in with. And then if, like no matter whether it got better or if it stayed the same or hopefully not, but got a little worse, that's a data point too. And so
Yeah.
I think as younger clinicians can get bogged down by having to do it all and having to test all the special tests, but really
Know it right away, like, know the answer right
yes.
away. Yeah.
Yeah, right,
Yeah.
right. They have to know, but I think patients really respond well to the humility of someone saying, this is where I think my hypothesis is going, but we'll wait and see after this trial treatment and see what happens."
Cool. I love that. All right. Before we wrap up with this, where can we find you either in the ICE app or on social media? Where can people tag along to your journey and learn from you?
Yeah, my Instagram account has some good nuggets. It is Revitalize Pelvic Physio, and I've got a lot of like just fun reels or free pieces of education and assessment if you are not quite in the pelvic space but want to hop in, or if you need to send something to your clients who may be interested in like, ooh, maybe I want some pelvic treatment on the ICE app, April Dominick. And yeah, that's where folks can find
Sweet.
me. Yeah.
Well, thank you so much. Everyone that is listening that stuck around, thank you guys so much for being here. Again, my name's Dr. Ellen Melrose, and next podcast, we should have Paul hopping back on with us. So, look forward to chatting with someone new next time.
Woohoo. Thanks so much.